This presentation is focused on content primarily from Module 2. It will be a brief overview of the Brazilian Unified Health System and population health in Brazil. We'll discuss what collective health is, how health reform came about in Brazil, the creation of SUS, or Sistema Único de Saúde, the main components of the Brazilian health system, SUS, and advances, challenges, and successes. I'll also briefly discuss what SUS is in the pandemic. Collective health is a term almost entirely used in Latin America, although it is one of the main things that we discuss on our trip to Brazil. I asked students to contemplate, does collective health mean public health in the United States, or are they different? In many ways, the majority of people argue that this is a movement that's different from public health as it's practiced widely. It has its roots in the preventivist, community, and social medicine paradigms, and it really rose in the 1970s and 1980s in Brazil. There was a lot of political, ideological, and social change happening at that time. Brazil was under a military dictatorship during that time, like many places in South America, and there was a huge social movement to remove that authoritarian regime. In the public health sciences, there was a huge criticism of the solely biological and curative approach of medicine throughout Latin America. In Brazil, collective health emerged really along these two main organizations. One is called SEBES, or the Centro Brasileiro de Estudos de Saúde, or Brazilian Center for Health Studies, and Abrasco, which is the Associação Brasileira de Saúde Coletiva, or the Brazilian Association of Collective Health. They were essential in the development of the collective health movement in Brazil. If you look at one of the articles I've asked you to read, it says, in Brazil, for example, activists in the sanitary reform movement and proponents of collective health in many ways spearheaded this moment of re-democratization and the articulation of a new social contract broadly. They also developed a comprehensive plan for participatory health reform that would be written into the 1988 Constitution and provide the architecture for the Brazilian Unified Health System, or SUS. I will say that these two organizations are key, and they have a major role in how collective health functions in Brazilian society. How do we define collective health today? Many argue it's a line of thought, a social movement, and a theoretical practice, perhaps harder to put in real practice. Arguments about the fact that collective health investigates the production and distribution of diseases in a society as a result of social production and reproduction. So as social processes are happening, they're determining the disease distribution in a society. The collective health space emerged from within the medical field as a criticism of only preventive medicine and an ambivalent rejection of institutionalized public health. And in the article I've asked you to read, it argues that Latin America, in particular the Latin American social medicine collective health movement, offers rich epistemological alternatives, but also systematic evidence and lessons drawn from attempts to move beyond neoliberal health policy making and establish more just, equitable, and inclusive approaches. Many of the articles in that entire issue of the journal that I asked you to read are focused on the influence that neoliberal health policy making has. Whereas in the beginning of the development of collective health, there was a strong emphasis on equity, on inclusion. Neoliberal health policy making has often used market forces to distinguish who and how we should be delivering health. In Brazil, there are some key components of Brazilian health reform. The health system before SUS was primarily an underfunded Ministry of Health that was really only focused on preventive services, a social security system that provided medical care for people that were formally employed, such as industry workers, railroad workers, different levels of service and coverage for those groups. But poor people really only had charity and philanthropy as their sources of health. So there was a major economic political crisis happening in the country in the 70s and 80s There was an end of economic growth, worsening child mortality, and a reduced legitimacy of the military regime, which drove civil society to organize and change the situations. Doctors' unions, organizations like SEBIS and Abrasco, and community health movements linked to the Catholic Church drove health reform in Brazil at this time. In 1988, Brazil developed a new constitution, and it decided in that constitution that they would state that health is a right of all and a duty of the Brazilian state, which meant that everyone was guaranteed rights to health and that the state had to be the provider of those services. In this same time period, during Brazilian health reform, a document was developed that sought to broaden the definition of health as the conditions offered to the population so that people can have access to food, housing, education, income, environment, transportation, jobs, freedom, ownership of land, and access to health services. All of this depended on how social production is organized that may generate inequalities. And this was really an integration of the concepts of the social determinants of health, but perhaps going even further. And if you read the article, they argue that the collective health movement goes beyond the integration of the social determinants of health. There are a number of laws that support the Brazilian health system. I mentioned the Constitution. There was a law in 8080, Law 8080-90. It regulates conditions for health promotion, health protection, and health recovery. And then the Law 8142 regulates community participation in SUS. That means that at every level, the city, the region, and the state, as well as federal, there are different stakeholders involved in helping the health society set priorities. They have conferences every 2 years, and they come together to set the priorities for how the health system will focus and function. And this is a really interesting feature of the Brazilian health system. It's called social participation in the best translation. It's where actors at many levels, both health providers, but also community members, come together and say, these are the priorities we will focus on for our health system. Unfortunately, as we'll learn, that while these laws are important and set up ideal functioning for the system, SUS has many challenges, and one of the more recent laws that has been passed limits expenditures for the next 20 years. Over 20 years, it's capped spending at 2017 levels and can only accommodate inflation. What are the key components of SUS? The main principles are universality, equality, and comprehensiveness. And the organizational principles around that are decentralization, regionalization, a hierarchy, and as I mentioned, social participation. And what's important about this is this was really a challenge for a country as large and varied as Brazil is, to attempt to achieve universal health coverage in a country that's almost the size of the United States with a very distinct population throughout is a real challenge. And I think it's one of the reasons we can look to Brazil to try and understand their approaches to universal health coverage. SUS intends to provide comprehensive, universal preventive and curative care through decentralized management and provision of health services. They say it's everything from vaccine, which is a preventive health service, to something as complicated as transplants. The main components of SUS include a financing component, which is funded by taxes at the federal, state, and city levels. It is chronically underfunded and was because at the time it was created, even though Brazil had eliminated their military dictatorship, the first elected president was still highly influenced by the politics of the region at the time and didn't intend to fund SUS in the way it should have been funded from the beginning. And although Brazil spends a good amount of its GDP on healthcare, many of those expenditures are from the household level and not from the government level. There is a private insurance system and private providers, and those integrate with SUS, and that SUS can actually pay them private providers to provide services that federal services aren't providing. But it makes a competition between the two systems. The private system has grown. There are private insurance plans. They often offer specialized medical services and strong public financial subsidies. So for example, if you pay for a private insurance, you get a tax rebate. And it incentivizes those that can afford it to pay for private insurance. People can use services in both subsectors, but they have to be able to pay. Or the access for SUS patients in the private sector is more limited. The main program component that most have identified has been extremely successful is primary care. This is administered through Family Health Program or Programa Saúde da Família, and one key component is that they integrate family health groups within the community. There's a doctor, a nurse, and 4 to 6 community health workers located in clinics that cover between 600 to 1,000 families. And the argument has been that the expansion of the family health program has really dramatically improved life of the Brazilian population. You can see many cities have increased coverage over time in this graph here. Family health program, vaccines, preventive care. However, secondary care in Brazil is more problematic. The supply is restricted and given preferentially to those people with private health plans. And it's also highly dependent on private sector contracts for therapeutic and diagnostic services. There are some things that have happened in secondary care that have been successes, like the program for counseling for HIV and AIDS, and also specialized services for mental health, where they've actually eliminated the use of sanitariums or mental health facilities, and they've allowed this service to be in the community and people that access it. However, the secondary care is problematic. It takes a long time and people are unsatisfied with the access. Tertiary care, high complexity care, is high cost procedures primarily by private sector providers that the government is paying, and they have to pay often at market value. So they're basically subsidizing these private providers. And it's very hard to control the costs and improve the efficiency. The system's not organized into a regional network, and it's hard to get access to these high complexity services. But because health is a right of the Brazilian population, people may actually sue to get access to these services. And that causes a whole nother set of challenges that the Brazilian health system faces. There are some good policies for high cost care in SUS, and one that's been highlighted is the list for organ transplants. It tends to be fairly equal in terms of who can get access to a transplant, independent of wealth. We know that SUS has had a huge impact on the health of the Brazilian population, as evidenced by a number of different studies. And the main areas where they think that SUS has impacted population health in Brazil is increased vaccination coverage, along with access to prenatal care and care during childbirth and postpartum. They've been established oral rehydration therapy in the country, and in control of AIDS and provision of essential drugs. It's also improved its health surveillance system. So we've seen a major decrease in infectious diseases for Brazil. In this figure, which is taken from the other article I've asked you guys to read, Masuda et al., you can see the access to care, either the family health program, which is mostly primary care, or private medical plan insurance in different regions of the country over the last 17 years. What you'll notice is that the South and the Southeast have the highest access to these private insurance plans and increased access to the family health plan. The North and the Northeast have lower coverage of those plans. Those tend to be the poorer areas of the country, whereas the South and the Southeast are wealthier areas of the country. And this demonstrates some of the inequalities. If the federal is only a portion of the funding, states and cities have to fund the family health program, they're going to have a more difficult time increasing coverage because they have to build it on their own economy and their own tax base. Challenges that the population is facing, and of course most of these arguments were being made well before what happens now in the pandemic. Old problems have persisted or worsened. Communicable diseases such as TB and malaria maintain high prevalence rates. Diabetes and hypertension have increased, so you're seeing a shift in not only some infectious diseases remaining, but also chronic diseases. And then, of course, new problems that have arisen in the last 20 or 30 years, like dengue and other mosquito-borne diseases like chikungunya and, of course, Zika. Violence has grown, including aggression with firearms, although it's illegal to own firearms in Brazil, and social and regional inequalities and the incidence and prevalence of these problems have persisted. For SUS as a system, the program suffers from chronic underfunding, and the private sector often contests resources and wins. Ultimately, the challenge facing SUS are political. They can't be resolved in the technical sphere, but society has to decide whether healthcare should be a social or individual issue dealt by the state or by the market. And as many have argued, these fiscal austerity measures imposed in 2016 have threatened the gains that Brazil made primarily in child mortality and health of mothers and children in the last 2 or 3 decades. And there's some concern that the system is so fragile that any change in funding will rapidly reverse all of the gains that have been made. Now, in the time of COVID-19, most argue that Brazil's biggest problem is their current president, Jair Bolsonaro, of course, most public health professionals. In a recent opinion piece in The Lancet, when asked by journalists last week about the rapidly increasing numbers of COVID-19 cases, Jair Bolsonaro responded, "So what? What do you want me to do?" He has consistently underestimated the impact and reduced the opportunity to diminish the impact in the population. He fired the health minister, who was respected and liked. The one that was put in his place resigned within 3 weeks because Bolsonaro was pressuring him to recommend unproven drugs like hydroxychloroquine. But even without the political vacuum that they're experiencing, many people in Brazil live in poor urban areas that are called favelas or slums, where they lack the opportunity for physical distancing and water and sanitation, and this may make them more vulnerable to the disease. In addition, there's a large informal unemployment sector that will continue to need to work because there's no social safety net to allow them to get unemployment, and the indigenous population is under threat, some arguing that what will happen in that community is a genocide. The Lancet paper goes on to say that while the population and scientific community is working hard, Brazil as a country must come together to give a clear answer to "so what" by its president. He needs to drastically change course or must be the next to go. Brazil has had a series of presidents in the last 4 years. Dilma Rousseff was impeached in 2016. Her vice president took over the presidency for 2 years, and in 2018, Bolsonaro was elected. So there's a lot of concern about him and his policies. He is in many ways similar to Trump, but of course also different. So I put some resources here for you guys to read. Some of these are available. Some of them I asked you to read if you wanted to expand further. These are some other resources for you. And I want you to think about, at the end of this presentation, what's one aspect of Brazilian SUS or its development that you found interesting? And are there any aspects of the system that remind you of the US? Is there any component you could employ in the US, and if so, how?